My name's Amanda, so I'm one of the dietitians at St Vincent's Hospital, and I just would like to acknowledge other people who have assisted me with this project. So Professor Vicky Flood, Dr Mark Halakai, Dr Stephen Cooper, Professor Alan Spiegelman, and our current Director of Cancer Services, Richard Gallagher. Basically, we're in the early stages of our project. We're looking at the effect of different nutrition interventions, be it a prophylactic feeding tube or a reactive feeding tube or simple oral nutrition support. We're looking at the impact of that nutrition intervention on some health outcomes for our head and neck cancer patients. So we're looking at nutritional decline. We're measuring that as weight changes and changes in their body mass index. We're looking at feeding tube complications, including patient mortality. And we're looking at any unplanned hospital admissions patients are having in relation to their nutrition. So today I'm going to focus mainly on the weight changes our patients are experiencing. So just to give you some background on the issue about why malnutrition is an issue in head and neck cancer, we know that at presentation it's quite a vulnerable population. So the literature puts it at 30 to 50% of our patients are malnourished at presentation. This has been associated with a higher rate of mortality, so 20 to 40% of deaths are directly related to cachexia, poorer immunity, poorer treatment response, increased number of hospital admissions and length of stay, and a poorer quality of life. So as we know now, it's all about the patient experience. We're not just looking at survival, we're looking at improving the patient's quality of life. So just some more background as well. In 2013, there was a Dutch study done by Languis. So she looked at 1,040 patients with SCC of the head and neck and found that even weight loss of 5% pre or during treatment was significantly associated with a decreased survival. So what we do need to investigate further is how we can address this. I've got the reference down there for anyone else to look at later on. Also, in terms of weight loss, it does have implications for radiotherapy dosimetry. So there are newer radiation techniques out there now, in particular intense modulated radiation therapy, which is very dose dependent, so it relies on accurate weight calculations. With our head and neck patients, it's very important that the mask fits nice and tightly so that you're actually targeting the correct area. So I've just put a graphic up here from one of those studies showing that weight loss of more than 10% in a base of tongue patient, if they had not been replanned, it would have resulted in a higher dose to the spinal cord, which is obviously, we don't want to be targeting that. So this is quite a busy slide. There are a few treatment centres who've tried to address this issue of weight loss and malnutrition in head and neck cancer. One centre in particular is the Royal Brisbane and Women's Hospital, and they've looked at trying to screen their patients for malnutrition at presentation, and the COSA head and neck guidelines are consistent with this protocol. They suggest that we should be considering a prophylactic feeding tube for our high-risk patients. So they're defined as a BMI less than 18.5. They've got severe weight loss at presentation, so 10% or more, or they're getting a high level of treatment, so chemoradiation to the oropharynx, nasopharynx, or pharynx. There are a few other hospitals who've adopted this approach, so Royal Darwin Hospital and Lismore Hospital. But what we're finding is this is still a very hot debate. Obviously, we don't want to be placing feeding tubes into patients if we're not actually going to use them. So in terms of what our centre does, we generally reserve this intervention for those who are unable to swallow or with severe dysphagia. So I thought it was a key point for us to be able to improve our patient care, to look at what our outcomes are showing. So we're conducting a retrospective cohort study of patient data and outcomes. We're doing this across campus. We're looking at the head and neck cancer patients with squamous cell carcinoma, and we're only looking at the upper aerodigestive tract. We're looking at those that are receiving curative intent treatment, and we're not looking at those with a tumour of the ear or skin, or only receiving single modality treatment. And we will be adjusting for confounding variables as well. So the health outcomes that we are evaluating up to 12 months post-treatment include the patient's weight at presentation and the percentage of weight they lose during treatment, the number of hospital admissions, the hospital length of stay, and any complications they've had associated with their nutrition interventions. So as we know, with feeding tubes you can have peritonitis, you can have the lesser complications of stomal site infections. So we really want to know what's going on there. And as a secondary health outcome, we're looking at the number of treatment breaks and treatment replanning instances that can be attributed to malnutrition, dehydration. So results to date, so I have collected some data on roughly 50 of our patients, and as expected in the head and neck cancer population, they tend to be a mean age of 60, so middle age, majority are men, and have those high risk factors at presentation for this cancer, so ex or current smokers 80%, and heavy alcohol use, so 50% of this population were consuming 40 grams or more of alcohol per day. And the key point really from this slide is that there's a self-reported weight loss of 30% at presentation. So even before they've had the major surgery, chemoradiation, there's already 30% of this population saying they've lost weight from tumour-related factors. And also the fact that when they're smokers and drinkers, we know that this is commonly associated with poorer nutrition status. So results to date I have data for 30 patients at the moment, and we're finding that the mean weight loss amongst this patient population is 10%, which is quite significant. So that's first presentation to end of therapy, and there is quite a range, but the majority are losing at least 5%, and it can go the whole way up to 25%. And many people think, well, there can be differences across the body mass index range, so what about our overweight and obese patients versus our underweight? And really this graphic is just to show that we've got the normal BMI up here, which is 18.5 to 25, but as you can see, the majority of patients, irrespective of their BMI, are losing between 5% to 15% of their body weight during their treatment. So I would really like to drive home that even if you have a patient who appears overweight or obese, we all really need to be looking out for their nutrition during their chemoradiation. In terms of weight loss by tumour subsite, at the present my sample size is quite small, so I haven't been able to see a trend to one particular tumour subsite. The majority are oropharyngeal cancer patients in this population, and again the main point is that the average amount of weight loss we're seeing is about 9%, with a variation of about 6%. And there's quite a range, so as you can see there's quite a need to be able to screen your patients at presentation to see who's going to be most at risk. So the main conclusions, and I hope to be able to present more to you soon. So patients with squamous cell carcinoma of the head and neck have higher rates of smoking and alcohol abuse, and these factors have been associated with poor nutrition status. The mean weight loss in this study we've found for these patients is 9%, which is quite significant. And our head and neck cancer patients can lose a significant amount of weight irrespective of their body mass index. So the future directions for our study, we're going to look at a model of care where we can appropriately screen our patients for malnutrition at presentation, and we want to make sure we're using the correct nutrition interventions and not overusing a particular intervention that doesn't get used by the patient, such as a feeding tube. And we ultimately want to prevent unnecessary hospital admissions related to malnutrition and feeding tube complications. So that's really it. Thank you.